My name is Dr. Ian Storch. I'm a board-certified gastroenterologist and osteopathic physician, and you are listening to DO or Do Not. If you are interested in joining our team or have suggestions or comments, please contact us at doordonotpodcast.com. Share our link with your friends and like us on Apple Podcasts, Facebook, Twitter, and Instagram. We hope you enjoy this episode.
Hi, my name is Jeevan Ambat. I'm a third-year medical student at the Alabama College of Osteopathic Medicine, and you're listening to DO or Do Not. Today we speak with Dr. Alan Yee, a board-certified neurologist and stroke specialist. Dr. Yee is what Dr. Storch refers to as a hybrid DO and represents the best of what our profession has to offer, combining conventional and manual techniques in a way that only an osteopathic physician can. After attending medical school at Turo, California, he completed an internal medicine residency at the prestigious Cleveland Clinic. He then did a 180-degree pivot and decided to do a second residency in neurology at the equally famous Mayo Clinic in Rochester, Minnesota. Wanting to be close to friends and family as well as warmer weather, he returned to California, where he now serves as Associate Clinical Professor of Neurology and Associate Program Director at the University of California, Davis Medical Center. Our conversation with Dr. Yee covers a broad span of topics, from his medical journey to applying manual medicine in his neurology practice to increasing mobility in patients after cerebral vascular accidents. He discusses his research, which seeks to describe relationships between somatic dysfunction and stroke patient survivorship. Dr. Yee is a truly inspiring osteopathic physician, and this is an episode you won't want to miss.
All right, Alan, thank you so much for being with us tonight.
Oh, it's my pleasure. Thanks for having me.
Alan, I just want to start by introducing the listeners to how we found you, and specifically Adina Leader, who is a neurologist at NYITCOM and a good friend of mine for a long time, texted me super excited about you. And basically, she told me that she approached you at this cranial class because you're a neurologist as well. And she was so impressed with you. And when she went to go talk to you and introduced herself, you said that you knew who she was because you had heard her podcast episode.
That was such a wonderful small story. And I think that's when I first started listening to your podcast. It was such a wonderful connection that I'd made in meeting her, just coincidentally, of course.
Yeah, that's awesome. So she was excited and she was like, this guy is awesome and you need to interview him. So I want to just start with the cranial aspect. So you're a practicing neurologist. You do cranial and we're in New York. And I almost term that a hybrid doctor, for better or worse, which to me is an osteopathic physician who practices conventional medicine and also has a specialty in osteopathic manipulation. So can you talk to us about that a little bit? And can you talk to us about osteopathic manipulation specifically with neurology?
Sure. And it just to sort of clarify, I was actually attending the cranial course at NYIT. I'm so used to calling the school NICOM because I think we probably graduated around the same era. But I was attending a cranial course for the first time as a student, so not teaching by any means. I'm very much a novice when it comes to the application of cranial work in terms of osteopathy. And so it was really a wonderful revisiting of the kind of medicine that I had loved from 20 years ago when I got introduced to manual medicine or osteopathic manipulative medicine. And so I currently do practice as a subspecialist in neurology. I'm actually a stroke neurologist, and I had practiced as a neurocritical care neurologist or neurointensivist for a number of years before I transitioned to my current appointment at the University of Davis as primarily a stroke neurologist. And so like you're saying, Ian, a lot of what I do in my day-to-day job as a stroke practitioner is caring for inpatient patients predominantly with a variety of kind of cerebral vascular diseases. But over the past year and a half or couple of years, I started a pretty fun and unique type of stroke recovery practice focused on OMT or OMM dedicated towards people that have survived stroke to enhance their recovery. And so, in a very brief nutshell, that's kind of where that had led to ultimately the cranial course. I've been spending a lot of time with my original OMT mentor from 20 years ago in the recent past, who is primarily an OMT practitioner in Arizona now. And he had spoken very highly of applying cranial work in his model of practice. And certainly as a neurologist, I'm very skeptical is too negative of a term, but I think I like to approach, I think, our field of manual medicine like any other therapy. There has to be good evidence. And so a lot of what I've been incorporating into my sort of standard stroke recovery practice as an outpatient is really incorporating studying and researching this style and area of medicine in terms of contemporary care or stroke care. And so that's where these two kind of areas melded together very well because it's not been studied before. And it's been really exciting kind of exploring that in my practice.
Alan, that's amazing. And the doctor that I always quote, and now I'm going to start using you as an example, as my hybrid doctor, is a physician named Balthazar, who's at NYU Long Island, which used to be called Winthrop. And he's a trauma surgeon. He specifically uses techniques and spoke to us about it in post-operative recovery and decreasing narcotic requirement for pain. So can you tell us a little bit about specifically what techniques you're using in the neurology ICU and for what specific maladies you're treating?
Mm-hmm. That's a fun question to answer because probably years ago, I tried to explore applying OMM or OMT to the inpatient acute neurological realm. And I realized the kinds of outcomes that you have to measure that really would speak to standard metrics of outcomes are very difficult to quantify in terms of neurologic outcome because it's such a long-term trajectory. And so I transitioned to the kind of practice that where I do apply OMT is really outpatient patients who survive stroke. And more specifically, it's patients that have some kind of physical disability, not language impairment such as aphasias or speech dysfunction, but it's those that are ambulatory to some degree that have some residual hemiparesis or lateralized one-sided motor weakness. Because although there are a number of different kinds of recovery opportunities, that really is limited to the first months, days, weeks when a person gets discharged from the hospital. But what happens to those folks, years when they survive, there's very little that is offered of significant benefit for recovery. So what I've explored over the past several years is there an area where manual or OMT can really mobilize these people and get them moving freer in their life to improve quality of life? So to more specifically answer your question, Ian, the kinds of techniques are predominantly direct. I've more recently incorporated cranial evaluation and really the cranial base because these people in general are very stiff, right? Because they've been living with spastic hemiparesis for so long. And so not only do I actually focus less on the symptomatic hemiparetic side, but the rest of their musculoskeletal system and how they get around, because I can't fix the brain condition that led to the hemiparesis, but I can, I think, affect and augment the other parts of their body that were not affected by the stroke. And so a lot of the techniques and treatment modalities are meant to mobilize those people with a combination of muscle energy. I do a lot of high velocity. And I know there's a lot of controversy around manual medicine or manipulating the cervical spine. Of course, this is my specialty in terms of stroke care. So I'm very sensitive to that fact. But a lot of it oftentimes is just getting people moving as best as I can. And again, I don't want to qualify direct versus indirect techniques, quote unquote, but it's really whatever gets a joint or a group of joints moving as best as I can.
Talking about neck manipulation, I know there's a lot of concern among some neurologists, specifically for chiropractic techniques and arterial dissections and things like this. Do you do neck techniques, and are those things that are concerning to you?
I do apply neck techniques, and I think this is where being a neurologist is very, I think, very important in understanding the mechanism of what caused the stroke. And that although this is a highly concerning kind of complication of cervical manipulation, it actually is extremely rare relative to the other causative mechanisms of stroke. And so depending on the epidemiology or the clinical profile, Those that we believe are at probably greater risk are the younger patients, as opposed to the 80-year-old, who has pretty stiff vessels, comparatively speaking, and what caused the stroke to begin with. So I do practice direct techniques, and it depends on the clinical scenario. I'd say I'm a bit far more gentle and conservative when it comes to older patients. And so I think performing high velocity in the neck, I do less often in the neck, but there are a host of other techniques, from articulatory stills techniques to muscle energy to counterstrain, to really mobilize, whether it's this overlying soft tissue structures or the articulation itself. So it depends on the particular dysfunction that I think is present at the cervical spine.
It's so cool. Again, I think the hybrid model is spectacular and so interesting. And it sounds like your work is great. Now, what hospital are you working at, Ellen, right now?
I'm at a major allopathic institution in Northern California. It's called the University of California, Davis. And for those of you that are less familiar with the West Coast, California has, I believe, 8 major medical and undergraduate and graduate universities called the University of California. You probably have heard of UCLA, UCSF, and UC Davis is one of those systems. We're just geographically in different areas, but we're kind of one major university system, but I'm at the center of UC Davis.
Alan, I certainly know UC Davis, and it's definitely one of the, you're being modest, but it's a pretty famous system in the United States, obviously. So my question for you on the institution, which is an allopathic institution, is how do your colleagues and how does the system look at your work? Are you mostly with MDs? Are there other DOs with you? And is there interest in manipulation from other practitioners?
I'll speak first to the Department of Neurology and then the university more broadly in terms of the healthcare system, as opposed to the undergraduate or graduate schools that are not, of course, directly involved in medicine. So in my department of neurology, we're a pretty decent sized department where we are 3 or 4 DOs in the department. We're mixed subspecialists from movement disorders. I'm the only stroke neurologist that's an osteopathic physician. And then broader within the University of Davis, there, I would say, comparatively speaking, more DOs in the primary care area as well as subspecialties compared to the other University of California hospitals. So I had been at UCSF for about 3 years before I came here about a decade ago. And there are very, very few DOs. And I remember the chair telling me I'd been the only and first DO to come through the department as a fellow and to stay on as faculty. And it just wasn't a very common thing for probably a lot of the similar reasons that you had encountered about 15, 20 years ago. But at UC Davis, I think in general, it has been a very wonderful experience, being much more, I think, open-minded from my lens and my anecdotal experience, where there had been a precedence where some primary care docs were practicing OMM, but really only offering it for the most part to their panel of primary care patients. And they, about a couple of years ago, did hire a part-time OMM specialist, and then, which was in, again, the area of primary care, but in terms of the neurologist practicing OMT, I actually recruited a recent neurology graduate from our program that practices exclusively OMT or OMM and neurology, kind of like me, but was hired as a first new OMT/neurology doctor in the Department of Neurology. I've been here a little longer than she had been, so I just sort of introduced it a few years ago as part of my general practice. I would say as an overall theme, the university has been quite open to, I think, clinically as well as scientifically. And I'd be happy to tell you more about the exciting work I've been exploring a little bit later on during the discussion.
Tell us now. I'm intrigued. Tell us about the work you now. I want to hear about it.
Oh gosh, I've been nerding out for a long time. I've been dreaming of some area of my clinical work in applying OMM or OMT. And traditionally, as you know, a lot of patients seek OMT primarily for aches and pains and backaches. And my mentor of 20 years, who is exclusively an OMM practitioner, that's his patient panel of 40 years. He sees chronic pain, and his name is Bill Brooks, and he's incredible. But that had never really been my thing. And so I thought initially I'd go into primary care, incorporate OMT into my general primary care practice. And that's why I actually done internal medicine residency first, and that's a different story. But over the years, I sort of tried to dabble a little bit, even in neurology training. It just really wasn't a good fit until the past handful of years. I really realized what has been driving me crazy is there's so much money, energy, and effort from the general medical community that tries to get stroke people better within the golden hours of acute neurology or acute stroke care within hours, right? So there's tons of NIH funding and research that goes into, well, how can we get people to the hospital quicker? How can we come up with a better thrombolytic agent to recanalize a vessel? Well, there's incredible scientists and clinicians that work on that area. Then I realized that's not where a lot of people still live and survive that need help after a stroke. And so I've been seeing stroke survivors for a decade where there hadn't been a lot of contemporary care that is of really major benefit to get them better and improve quality of life overall. And so that's where I really started to explore manual medicine. So I've been mobilizing people anecdotally for a couple of years. And then over the past year, really put a lot of energy into it. Again, recently gotten AOA funding to study the association between somatic dysfunction. And ultimately, I'm planning for a randomized trial in stroke survivors and the relationship of somatic dysfunction, quality of life, and stroke survivorship. So that's the really exciting stuff I've been exploring recently.
I mean, this is obviously, Alan, exactly what OMT needs. And it's interesting. I was recently speaking to an MD before doing a podcast interview, and he kind of said that whenever he looks at OMT, it always says needs more study. The studies are small and say need more study. And I think a lot of things in medicine do that, not just OMT, obviously, but we need someone like you and someone like Dr. Balthazar to actually get us some data to show that these therapies work. And it's not easy, right?
No, it's been very challenging, and I 100% agree with you because coming from a very traditional contemporary training background like you in quote allopathic medicine, it's really scientific rigor that I think that our profession really would find of added value, because anecdotes are really powerful, but I think to insurance companies, to the broader medical community, that this is the next level added to it. And this just happens to be an area of my sort of day job that could benefit from it. And where I think a lot of uncertainty that I'd had growing up in osteopathic medical school is when you're taught a technique or an examination diagnosis, how can you reliably reproduce what you're finding, right? Between your attending, between other students. And so a lot of what I'm applying to this study is incorporating a diagnostic model to try to reproducibly demonstrate that if Dr. Storch were to physically examine the joint, that you and I would agree upon the same finding. And so a lot of this first phase of study is really to intra-examiner reliably test that sort of hypothesis in question.
And Alan, just to take a step back, and I think you'll agree with this, the discussion that I had with the MD that I'm referring to, he sort of had an idea that everything in medicine needs to be evidence-based. And certainly we love evidence in Western medicine. And I'm sure you'll agree, as do I, that evidence-based medicine is the way that we should practice. But that having been said, most things that we do on a daily basis in medicine that we know are correct do not have evidence behind them. So just because OMM doesn't have evidence doesn't mean that it doesn't work or that it shouldn't be practiced. However, as you said, to take it to the next level, having a better basis of evidence, I think, will bring it to the forefront.
Oh, I 100% agree with you, Ian. That is where the next very important level of not only primary care can address OMT or OMM in terms of evidence, but subspecialists, like whether it's neurology or gastroenterology or otherwise. But I agree.
Alan, I'm going to ask you a little bit of a silly question, and then I'm going to shift gears and we're going to talk about you. But you've been, just for our listeners, before we hear the story, again, you talked about UC Davis, but I looked at your resume. You have been at the who's who of hospital systems in your training and your career, in my opinion. So you've been at Cleveland Clinic, Mayo Clinic, UCSF, and now UC Davis. Is that all correct?
That's right. That's correct.
That's amazing. Like your resume is amazing. Does everybody tell you that when they look at your CV? Are they just like blown away?
No, you just get lucky a lot of times. I think a lot of hard work and good luck and good fortune and cross my finger a lot, my fingers a lot. But yeah, it's been a lot of fun.
Okay, Alan. And again, before we go into your story, put you in the hot seat a little bit. If you had to pick one of those hospitals or healthcare systems to say which one you thought was the best, could you pick one?
Oh my goodness, that's an unfair question.
You don't have to answer if you don't want to, but they're all great.
Oh no, my goodness. I think for the different to try and not get too worried, the different periods of my life, each institution had its purpose. The Cleveland Clinic was stop number one, and they made me a doctor, no question. Mayo Clinic was stop number two. They made me a fantastic subspecialist. And UCSF was of course another incredible place, and I think that gave me the confidence to practice all the things that I'd learned. But I think to begin with, and maybe we'll get a chance to talk about this later, the medical school I went to was in Kansas City, and if it weren't for my experience there and Dr. Bill Brooks, the OMT mentor, I think Bill really was the first clinician that took me under his wing that really taught me how to think critically, even as an osteopath, to be rigorous and scientific about things. And so I think, it is unfair if I try to say CCF or Cleveland Clinic was better than Mayo or whatever, but they all were amazing.
Again, I apologize for putting you in the hot seat, but I appreciate you taking the high road. So, can you tell us where you grew up and when you decided you wanted to go to medical school?
I grew up in Northern California, in the San Francisco Bay Area. There's this little town called Rodeo that's just about 20 miles outside of San Francisco. And I went to junior college for a few years and had no idea what I wanted to do. I have an older brother and younger sister. I just sort of took the classes that my older brother took, which were very random. And just, I think, struggling is too negative of a term, but really explored lots of different things. And really, when I transitioned or transferred into a four-year college in San Francisco, I said, well, let's just try biology because that's what I guess I'm supposed to do. And at that point, I still really had no defined career choice. And as I met other smart kids in college, I said, boy, you guys sound so intelligent when you speak. And what are you going to do when you grow up? And so I started meeting lots of other students in the sciences and in the language arts. And I kind of tended to gravitate more towards the biological sciences because I was terrible at English and grammar. And I know that you're a literary person, just listening to your recent podcast. But as I met more and more folks in the sciences, I started to meet folks that were going to go into physical therapy and ultimately medical school. And of course, this is in the mid 90s and the late 90s that people were so cutthroat, at least it felt that way, that were pre-med. And I said, I'm not like that. And I really didn't have that kind of personality. I didn't think I did, at least. But I really found out that I really enjoyed the deeper sciences. I hated chemistry, loved OChem, really enjoyed biology. And if it weren't for me sitting next to a guy named Dan Shadoan in OChem lab, who was a pre-osteopathic student at the time, and he was doing post-bac work, and I hope that Dan didn't mind me describing his story, because if it wasn't for sitting next to Dan serendipitously, I would have never heard about osteopathy. And I was just shopping around for some kind of healthcare career. I was really into martial arts at the time and anatomy, and I was just doing general dissections for my anatomy professor. And so as I got to meet Dan more and more and get to know him, he's saying, hey, Alan, have you ever, because he was into martial arts as well. And he said, have you ever heard about osteopathy? And he said, it incorporates a lot of musculoskeletal medicine and movement and da-da-da-da. And so we really hit it off. And I think around this time, I had met some wonderful mentors, namely my anatomy professor in college, who was actually an entomologist by training and was a scorpion expert. And he also really encouraged me to think about going to medical school. And then he had known about DOs and didn't really know what they were, what they did, but knew that they had a different specialty sort of to them. And it was sort of the perfect time. And it just was the perfect world and just got lucky, I guess. And met lots of people that encouraged me, of course, my family. But I think the rest is history, kind of putting all those parts together at that time.
And then you went to medical school in Kansas City, is that right?
Right, right. At the time, it was called the University of Health Sciences College of Osteopathic Medicine.
I interviewed there on my way to Kirksville when I was applying, and I loved it. I actually met my roommate from med school at NICOM when we were both interviewing at UHS, and we both loved it.
Oh my goodness, no kidding. It was an incredible school. Unfortunately, they didn't keep you, but I had a great time there.
So you spent 4 years there, and when during your education there did you decide that you wanted to be a neurologist? How did you come to that determination? And then can you tell us about oh, actually, I'll rewind. So how did you, I'm going to edit a little bit. Obviously, I have a little insight. So when during your time in Kansas City did you pick your residency? How did you pick your residency? And can you tell us a little bit about your journey into residency?
I loved neuroanatomy during the first 2 years of pre-clerkship schooling in medical school. The neuroanatomy professor at the time was amazing, but there wasn't a lot of therapies that were really hot topics in neurology, in the clinical discipline of neurology. And then we move into third year, and I realized I really loved learning about hyponatremia and about hypothyroidism and all the general sort of medhead stuff. And I still had been very interested in manual medicine. And I had spent 3 years outside of the traditional OMT lab, going to Dr. Brooks's house and during those first 3 years of medical school. So again, I really tried to get a lot of skills in place for practicing whatever I ended up doing, manual medicine. And I realized that going through third year, I really loved the complexities of internal medicine. And I figured, gosh, if I'm going to be able to incorporate OMT, probably primary care is where I can do it. And I thought that family medicine might have been a good place. Delivering babies was not my thing. Taking care of gestation and pregnant women was really a very intimidating area of medicine. And so I gravitated towards general internal medicine, probably for similar reasons as you. I loved complex medical conditions. And that's what brought me in to apply for medicine residency. And why I chose the Cleveland Clinic as opposed to a California program is a fun, odd story that has some relationship to New York. So I was doing a emergency rotation at the St. Barnabas Hospital I think it's in the Bronx, right? It's affiliated with NICOM or NYT. And while there, one of my co-classmates was also rotating, and he saw me clicking through the ERAS applications, and they were 8 California IM residencies only. And as you walk by me, he says, why don't you apply to these other programs, Mayo and Cleveland Clinic? They're quote DO friendly. And this is really in the early 2000s. And at the time, there was still some stigma behind DO students applying to allopathic residencies. And I said, okay, let me select Cleveland Clinic. And I was dead set on staying in California. And I'm a California kid, born and bred. And New York was amazing, but I was pretty intimidated taking your subway. So I said, well, let me go back to California. And so I got an interview at the Cleveland Clinic, and my goodness, that institution is amazing. And I was so impressed by the rigor of just their morning report and the chief resident and how intelligent all the house officers seemed. And so that really sold me. And I thankfully didn't bring my wife to interview because it was really cold and it started to snow, and we have never lived in snow. And I don't think she would have agreed to have come if she had visited Cleveland with me at that time. But that was the medical story.
Alan, a couple of things on that. Number one, I ended up at NICOM and not in Kansas City because of a girl, which happens. And then I actually interviewed also at Cleveland Clinic a few years before you did. And I thought it was like Disneyland for doctors. I was like, this place is amazing. And we looked at Shaker Heights. We looked in for places that we might stay. And I thought Cleveland was great. I'm a bit of a Cavaliers fan. Of course, that was a little later when LeBron ended up on the Cavaliers. But I loved Cleveland. And I ended up in New York because of a girl. But, that's how things go. But can you tell us a little bit about what it was like living in Cleveland, especially coming from California, obviously, and what it was like being a DO at the Cleveland Clinic?
So the city of Cleveland was pretty cool because I'd never, number one, lived in that kind of environment where it snows. And so that was probably the roughest thing to get used to was black ice and what is that stuff and learning how to salt our front door but once we got over that, it was my wife and my just married, we didn't have kids yet, and it was just the two of us, and so going around Cleveland Heights was great. The clinic itself, amazing, and you visited that institution. It really was a Disneyland for medical trainees, and I can speak on behalf of the medical subspecialties, including the surgical subspecialties. Every subspecialty known to woman and man are at that place, I thought at the time. There is a pulmonary sarcoid expert. There's a GI sarcoid expert. It was incredible, right? And I assumed that every medical institution is like this place. And so there were scientists and researchers and clinicians dedicated to these subdisciplines. And so I think learning from these experts was what I expected every place to sort of be like. And I came out of that program. That's when I told you in the beginning, I think CCF or Cleveland Clinic made me the doctor that I am now. It taught me how to be efficient, to be rigorous, to do the best I absolutely can for the patient. And I think that gave me that degree of medical confidence, I think, because you were pretty independent. And I think despite there being this sentiment, again, this is in the early 2000s, that institution really only catered to the fellows because it's a very fellow-heavy institution. That was absolutely not the case. The GI program is fantastic. And again, I'm preaching to the choir. You're probably much more knowledgeable about powerhouse institutions, but the GI program there was really incredible. And even as a future neurologist, I didn't know at the time when I was a medical resident yet, I loved cardiology and GI because of these faculty, fellows, and the co-residents I trained with. So I don't know if I directly answered your question, but really I had the time of my life there.
Yeah, so just the only little extra question is, were there other DOs in the program with you? And what was it like being a DO in your first powerhouse institution after medical school?
I thought it was a very open institution. There actually are many DOs at the Cleveland Clinic and a number of faculty leadership within our residency program, as well as outside of the residency, were osteopathic physicians. So I felt absolutely no stigma, no concerns. And taking DO candidates was commonplace, and I think it continues to be commonplace in that residency program, speaking for internal medicine.
So now, Alan, you went from internal medicine to neurology. Now, so these are like this is not a subspecialty of medicine for those of our listeners that aren't aware of that, but neurology is a separate specialty. Usually people either pick internal medicine or neurology. So when did you decide that you wanted to be a neurologist? And how was the transition from internal medicine into neurology, and what was the application process like?
I would say going through my internship year, which was quite rigorous, and no internship year is fun, that I started, again, fell in love with many of the IM subspecialties. And it was probably my mid-PGY2 year where I had done our mandatory neurology rotation as part of our residency program. I worked with a neurologist named Dr. Levin, who was the old school neurologist with the little black bag that you kind of can see in your mind, a bow tie. And he was a very humble and quiet person. That man was a clinical genius. And I was so enamored and impressed by his clinical acumen, his history taking. And I'm a huge aficionado of the physical examination and was so at awe by what he can identify just by physically examining people. And again, just at the same time, became really close friends with some neurology prelims. As you know, you grew up in residency being very close to your categorical medicine, to the other prelims in your institution. and some of whom were neurology prelims. And so they whispered the sweetness of neurology, and I met Carrie Levin. And at this time, I'd still loved neuroanatomy from med school. And I figured that the other medical disciplines that I was considering for fellowship was either rheumatology, oddly enough, critical care, because I'd done a lot of MICU at the time. And of course, you kind of fall in love with what you're doing. And so, what am I going to do with all this? And when push came to shove, I think I reflected on the fact that I would have been miserable is probably too negative. I think I would have regretted not doing what I love to do, which was neuroanatomy, whatever that meant as a career. And so I said, let me give it a shot. The duration of neurology residency is the same as a medical fellowship. If you want to be an interventional cardiologist, you're going to do 3 years of cards and then another year or two of interventional. Even with pulmonary, right? Or GI, if you want to do advanced endoscopy or sonography, it's probably another extra bit of time. So in my mind, other than having my student loan be prolonged from paying back, that was really the only negative, I think. And so I said, let's give it a shot. And if I was really unhappy as a neuro trainee, I would have completed medicine and taken a job as a hospitalist and called it a day.
Now, did you have to reapply? Did you have to go through ERAS again after you finished? And then I've heard these stories that if you do one residency, like the government only pays for one, so is it a difficulty funding if you switch? Is that true?
No, I had the same concerns, and that wasn't the issue. I had asked, I can't recall if it was ERAS or the institutions that I applied to that specific question. Number one, do I need to repeat an internship? And the answer was no, because you're a board certified internist when you come in. And number two, is there's a concern about funding. And really there wasn't, because to be a neurologist, you have to do an internal medicine internship year anyways, that is funded. And then 3 years of dedicated neurology, which are funded sort of separately. Because at the time, there were two ways to complete a neurology residency. You would go into an internship year at the same institution, followed by 3 years of neurology at the same institution. Or you would go elsewhere for your internship in medicine prelim, and then go to your final destination in neurology residency for 3 years. And so it wasn't an issue for me. And I did have to apply through ERAS again, and you apply and go through the match just like you would going into any other residency.
And I guess you went through the match and you ended up at Mayo Clinic, which is, again, doesn't stink, right? We
Right. No, it wasn't a bad place, Ian. And the funny story is, this is not speaking from arrogance, but when I applied for neurology residency, it was the end of G2 year in medicine, and I just had my first kid. And maybe we had found out we were pregnant with our second child. And I remember telling my wife, I said, I'd never visited Mayo. I've heard about it on milk cartons, right? But I'd never, other than sort of the publicity of it. I said, you know what? We just bought our house. I love Cleveland Clinic. The neurology program's amazing. Mayo has to be that good if I'm going to pluck you and our new baby and move to another yet colder city in the United States. And I'm going to tell you, when we visited for interview, oh my goodness. Not only do they roll out the red carpet, but it was like probably Disney World in Florida. If I compare Disneyland in California, it was, oh my goodness, an incredible facility. So anyways, the rest is history. It was really wonderful training.
And again, I'm going to just repeat the same question. So now you're a DO at Cleveland, which is, again, one of the best in the country. And then you're going to Mayo, another center, which is one of the best in the country. Were there DOs there? And how did you feel as a DO at Mayo Clinic?
So I've had this personal sort of bit about me where I've been very invested in my own education, and I kind of like, and it didn't really matter where I am. I'm just going to give it the best shot. And I've probably have had this sort of sub chip on my shoulder because of back in the 90s, when you're reading about what is an osteopath, there was a lot of negativity from the popular press about it. And even going into medical school, even though I never felt any sort of stigma against me going through and applying through residencies, I think I always just kept that probably unnecessarily, but that fueled a lot of my determination, I think fire to be really motivated to learn. So when I get to Mayo, I really felt no negativity towards me as an osteopathic physician. There was one DO that was on faculty, and as I went through the residency, one of my co-residency classmates was also the DO, and so I knew that Mayo took DOs periodically, and that Mayo, as far as I understand, and they still really wanted the best candidates, whatever that meant. And my interview went great. So I think that all in all, I didn't feel any unusual discomfort as an osteopathic physician while going through training there, and had made wonderful relationships with many of the faculty. And even as I applied for neurocritical care fellowship, I'd almost stayed there. But if it wasn't for the fact that my wife hated the snow and still hates snow, that was a major determining force. Happy wife, happy life. While we had to move back to San Francisco. And just for a little bit of history in terms of osteopathic medicine at Mayo Clinic, the very first DO resident was at Mayo Clinic Neurology. In other words, there's a very famous physician, I think his name is Dr. Goldstein, that back in the 50s or 60s, they had accepted him into their neurology residency, and he really set a precedence. He became one of the most influential neurologists in the United States, went to the NH, was very instrumental in, I think, starting up the NH neurology and stroke program, if I'm not misquoting his legacy, but really, I think probably and paved the way for future DOs to eventually get their foot into Mayo Clinic Neurology. So really fun history.
So now you've done 6 years of training, right? You did is that right? 6 years? Yeah,
right,
6 years.
Right.
So you did internal medicine, full residency. So you're a full board certified internal medicine doc. You finish a neurology residency. You're now a full neurologist, and you decide to do a fellowship also. Was that a tough decision as far as continuing your training and not just being like, look, I've done enough, I'm going to go into practice? What made you decide to pursue the fellowship? And can you tell us what your fellowship was like at UCSF?
Sure. My fellowship was in neurocritical care, and I was in my second year of neurology residency at Mayo. And of course, mentors speak very loudly. And when you see faculty that are just brilliant and they take you under their wings, and if it wasn't for Dr. Ravenstein, who is a neurointensivist at Mayo, who taught me how to write, who taught me how to interpret papers. And let me tell you, Ian, the first manuscript that I had written with him, he made that paper bleed with the amount of edits. And I think just that degree of mentorship and really taking me under his wings, as well as the other neurointensivists, Elko Vedics, it really made me fall in love with the discipline. And of course, they're neurointensivists. So that's the discipline where we care a lot for people with critical brain injury that are in coma, with critical traumatic brain injury, strokes, you name it. And so that kind of said, well, gosh, they look like they're really happy, and I'm loving the discipline. So that's what brought me to applying for that subspecialty in neurology. And at the time, I only applied to 3 programs. One was staying at Mayo, the other was UCSF in California, and I think maybe in Los Angeles might have been the other one. And we're from the San Francisco Bay, and I told you, happy wife, happy life. And we're 2 kids in, little babies, and that's a tough time, when you're trying to raise a young family. And so we had to move back home, which was the main driving force for going back to Northern California. And I was very fortunate, and thank God that San Francisco or UCSF took me. I was very fortunate. Probably my mentors had a lot to do with it. And again, good fortune and good luck, but that's what brought us to San Francisco.
All right, Alan. So then you decided you wanted a job, and obviously we started at the beginning where we are now at UC Davis. So, and again, I'm going out of order. So we usually start with this, but there's so much that I wanted to talk to you about, and you've been great. Can you tell us about what your week looks like now? Like, what are you doing? You already told us you're doing some ICU and some outpatient neurology. Can you tell us about what your general week or month looks like, and maybe what type of patients you see on a regular basis?
Sure. So I'll maybe describe it broadly on a monthly basis. I'm at an academic center, so we help run a house officer program amongst fellowships. And so I'm the associate program director, so I wear a couple of different hats in med ed, as well as the clinical discipline that I practice in. So I'm on stroke inpatient service about 1 week out of 4-ish. And during that time, we run a very, very busy stroke service where we admit patients with stroke, with ischemic and hemorrhagic stroke. And we have lots of medical students and residents. And we also concurrently offer telestroke care to not only many other institutions across Northern California and almost to Southern California. So we're doing a lot of drip and ship where we're thrombolysing people at St. Elsewhere. Then we transfer them to our institution to perform endovascular thrombectomy for emergency stroke care. And that's what that busy week looks like, where you might not get a ton of sleep because you're on 24/7 and we're triaging people from our residents in-house as well as all these other institutions. But then the other time when I'm off of inpatient service for the other three weeks or so, I do a lot of fun stuff where I have 1/2 day of stroke clinic where it's just seeing stroke patients, new consults, as well as follow-ups from hospital. But 2 Fridays out of the month is my OMM stroke recovery clinic, which has been my baby. And so outside of the clinical practices that I have that I described, I do a lot of medical education, running simulation labs, didactics, and training the School of Medicine as well as our residency. But I have other research work that I've been spending a lot of time in the recent past doing. So in a nutshell, it's really a fun mixture of academic practice at UC Davis here.
I recently did an interview with a psychiatrist who awesome. And she kind of specializes in burnout. And she talked a little bit about burnout that she's had. And one of her comments now in her life is that she feels that one of the best ways to avoid burnout is just to have your hand in a lot of different things and stay diversified. And it seems like that's what you're doing. Would you agree with that? Do you get burnt? I mean, you have a lot on your plate. Does it get tough, or do you feel like that diversity is really what keeps you fresh?
Oh, there's no questioning that the diversity has been invaluable. And as opposed to the previous job I was at, I had practiced there for about 4.5 years, and that was a private demic kind of practice. And I don't mean to rewind too much, but I think it'll give this story a little bit of grounding to it. So after fellowship at UCSF, I stayed on as faculty for about a year almost. And the expectation was to get independent or intra or extramural funding. And that's very stressful for a young kid that's just coming up. And I was terrible at grant writing, and I was terrible at research. And the project that I had been working on was good, but I don't think it was going to get a lot of traction. So then I take the next job, which was a very busy neurocritical care and stroke job. And that was a mixture of private practice-ish model mixed with some teaching at the institution. I got pretty burned out there because you're working about 26 weeks out of the year doing very intensive stroke and neurocritical care kind of work. And I realized that it didn't give me enough breathing room to have variety in my practice because I was still very interested in medical education. There just wasn't a lot of space for that because, as you know, when you come off of a week of service or call, it takes a bit of time to recover. And then when I took this job at UC Davis almost 7 years ago, it gave me flexibility and it really allowed me to stretch my wings in terms of being a better medical educator, really dabbling in research and really eventually getting to where I'm now. And so to me, I agree with your comment that your psychiatry colleague had commented on that. I think giving your personal freedom to explore interests, whether you fail, flop, or succeed, that's invaluable experience. I mean, it truly has been for me, at least.
That's awesome, Alan. Alan, you've been awesome. Your story is awesome. You're awesome. We have one last sort of grand finale question that we ask all of our listeners, which is, can you give us one piece of advice that you've been given by someone else during your education that's been valuable or invaluable to you that you would like to pass on to our listeners?
I'll try to be succinct. My residents will tell you that I get very wordy, but Dr. Stan Williams, the entomology anatomy professor in college, told me from the very beginning, keep your ear to the ground. And I've kept that all these years. And I think what he meant by that was take advantage of the resources that are in front of you. Make the most of what you have and what you don't have, and you want to work at it. And that is what I've held very close to me. I didn't come from a wealthy family. I didn't come from a very sort of legacy background, but I think there were lots of stars that I wanted to reach for, and I think I just kept going at it. And that was my interpretation of his advice. And I think staying humble has been, I think I try my best to stay humble because I've had my hand handed to me so many times that, like you said in our meeting, and there's so much of what we do that doesn't have evidence. And being open to the fact that I don't know needs to be an answer, and being comfortable with that and being grounded with that. And the last bit of wonderful advice from an old employer, he said, his name is Dr. Goldstein. He said, Alan, you should smile. And what he meant was, I think what he meant was that, smiling is very inviting, be it to patients, being it to colleagues, or whatever the case may be. So really probably those three things I've kept very close to me, and I found very valuable. So, to answer your question, Ian.
That's awesome advice, Alan. And again, thank you so much for spending time with us tonight. I really do appreciate it.
Oh, it's been an honor. Are you kidding me? I've been a fan of your podcast for a couple of years, so it's been really a wonderful honor. Thank you for having me.
A pleasure. The pleasure is all ours. Thank you so much, Alan.
This concludes our episode of Do or Do Not. Send all inquiries, comments, suggestions, and even let us know if there's someone you want us to interview to doordonotpodcast@gmail.com. Don't forget to like us on Facebook at Do or Do Not Podcast for updates. If you enjoyed our podcast, please share it with your classmates and administration. We have plenty of more interviews lined up, and we're excited to share them with you. This is Tian Yu Shea. Thank you guys so much for listening to Do or Do Not.